All right, come on, moderators. Yes, good, thank you. Come on up. Now we have about up to 45 minutes for this part, and we have, I'm trying to see, because we merged two groups, so we have one fewer moderator than was the number 8. Were others merged as well? So I'm expecting 6 people up here before we get started. So I've got 4. I'm missing 2 moderators. Oh, 5, Alina tells me. We only have 5 moderators. Okay, so we're just 1 short. Calling all moderators. Okay. Martha was a moderator? Okay, so somebody can point Martha to the front of the room when she gets here then. There she is, our trailing moderator. We're calling the reports. So please get it. Great. So with that, I'm going to ask each of you to, since we have 5, to try to keep your remarks to less than 5 minutes so that we can have this plenary conversation about the similarities and across all the groups. Now, how many what's the numbers? 1, 2, 3, 4. Should we go in order or should I just go by people? Since they all merged, why don't I just call on each moderator in order to speak? So let me start at the other end with my group, since that gives Martha a bit more time to get settled. And please go ahead.
Sure.
And I'll get my timer.
I'm Steve Smith, University of Florida. So our group was tasked with talking about communication and dissemination and priority research issues around that. So we had a great discussion, came up with 12 or so big picture ideas, and we whittled those down to 3. So I'll just kind of go through our grid, I guess. Is that best strategy, Lisa? Is that what you're looking for? Okay.
Yeah, sounds good.
So the first priority research question issue we came up with was, what's the best way to sort of frame research communication? And included in that is, what's the role of social media and choosing the right messenger to tailor the message best? We felt like the primary audiences would be obviously researchers, academic communication offices, government communication offices, public health sector would be interested, advocacy and professional societies would be interested, and also sort of knowledge brokers who would be passing along results of research. As far as who would conduct it, we felt like there'd be an obvious this would be sort of an obvious area for like communication scientists. Lisa brought up the Frameworks Institute, which I guess does work in this space as well. As far as resources and incentives went, obviously money, which I think will probably be the case for pretty much every research idea, but also we felt like public-private partnerships could be a good sort of resource for doing this type of research. And then as far as challenges and strategies for overcoming those challenges went, we felt like the ability to sort of maintain integrity while providing results. So in other words, we felt like some researchers would be challenged with having to report results before they were quite ready to report results, having to simplify the message to the point that they're not comfortable with giving that message, since we all like to talk about the sort of caveats that have to do with our research and that sort of thing. And we also felt like traditional models of research may be a challenge in that particular area. The second priority research issue we had was understanding what is needed to incentivize researchers and more generally the research machine, including academia, to try to increase their involvement in dissemination and implementation research. So as far as primary audiences go, we felt like academia and research funders would be primary audiences, as well as journals. With regard to who will conduct, we felt like agencies or research funders would be big sort of drivers of this, possibly academic researchers as well. Again, money would be important, and mostly we felt like it would be really important as a resource to be able to apply pressure to funders that they be forced to demonstrate impact, which we felt like so particularly in the government agencies, there's usually some sort of area where you have to describe what the dissemination and implementation will be, but it's not really enforced very well. And I mean, you can usually get by with just saying we're going to publish a couple of papers and present at national conferences, and that's checked off as being dissemination and implementation, or at least dissemination. For challenges and strategies, we felt like sort of forcing accountability would be a difficult thing to do. And also figuring out how much is sort of, where's the fine line, and determining how much is needed to incentivize academic folks. And we also felt like the idea that, support as a concept, supporting dissemination is much farther ahead than actually really supporting dissemination. So everybody likes the idea of disseminating information, but when it comes to actually doing it, that's not embraced quite as well. And then thirdly, I'm trying to keep it under 5 minutes here. Thirdly, we've thought that the other priority research area was how to meaningfully increase the exposure of researchers to end users of their research and vice versa. So obviously for the primary audiences there, researchers and end users would be important, but also intermediary organizations like professional societies, advocacy groups, and also funders would be interested in that as well. Who will conduct? We felt like researchers and end users would be the sort of primary people who would conduct that type of research. And then for resources and incentives, we felt like it was important that you have funding for the time commitment necessary to sort of build those collaborative relationships. We also felt like it was important that there be incentives to show a strong level of collaboration, both from funding groups, but also within academia. Like you get credit for the time devoted to building those relationships more than just an occasional meeting or letter of support from the end user or collaborators, so to speak. And then also we felt like it could be incentivized by some of the accrediting bodies for schools that researchers exist in, or public health as well. And then lastly, the challenges and strategies. We felt like, obviously relationship building is a big time commitment, and trying to get those two people to those two groups to interact at more than a surface level takes quite a bit of time. We felt like there could be greater value placed on pragmatic research and pragmatic trials, and also a greater emphasis or greater recognition that the ability to sort of translate rigorous research into the community setting that's sort of an enhanced ability or a higher level ability, not something that should be looked down upon, so to speak. And then we also felt like a strategy would be to give researchers and end users a sort of primer or pitch as to what are the benefits to those members in the collaboration relationship. So I'll end there.
Great, Steve, thank you. So that was 7 minutes, and I'm going to give everybody 6. So try to shave off a little time, because we do have time after the allotted time here for reflections. But Michelle.
So our group was looking at root causes, and we had 3 big areas that we had a very lively conversation about. The first was employment, the second education, and the third housing. Around employment, there were a lot of research questions and issues that came up, things like the impact of wage levels and benefits on health outcomes, the role that labor plays in health broadly, the continuity of employment and the role that plays on health, disparities in the labor force, particularly focused on participation, just to be clear, it's not necessarily the unemployed category where people are looking for work. We spent a lot of our time talking about those folks that are not actually looking for employment, so are not part of the labor force, and understanding the barriers and challenges that they face. Understanding job insecurity and the conditions that create that. Also understanding, really thinking about the time dimension in terms of the research that would be done in this area, and the payoff for the intervention over a specific time period. We felt that that was particularly important for people who would fund it, as well as businesses that would look to implement job creation investments. Also building off of Nancy's comments from earlier this morning, really looking at the history of the federal job creation efforts and the pluses and minuses to that it's had for our nation, and the implications that that has on community health broadly and population health. And then two of the last areas within that category of employment that we felt needed to be looked at were state and local social costs of joblessness, as well as really looking at a synthesis of the evidence so that we could do a better job of developing toolkits for both large and small and medium employers to help them understand how they could better facilitate health through employment. So that's our issues. Primary audiences here, we really felt like state and local policymakers, mayors, NCSL, local Chamber of Commerce and business leaders, owners and investors in business, as well as potentially workforce investment boards and the public. The last area of primary audiences that we talked about was really thinking about the anchor institutions, if the community has any, and their role as employers and the role that they could play in helping us to understand the needs and also the implementation issues around this body of research. In terms of who would conduct, really wanting to involve multidisciplinary teams, you name it. We pretty much talked about different disciplines being involved and working together to answer these questions. And one area that I'll just call out was really engaging business schools and connecting them both across business schools to answer this, but also to connect business and public health schools with economic theory as well. There were lots of resources that we talked about, particularly thinking about business interests and trying to garner their support both from individuals, companies, and associations that are starting to broaden their understanding of what it means to have a healthy workforce, a healthy and engaged workforce. And then also tapping into the global research that has been done on employment and its impact on health. And we had some examples of trade and apprentice models that we felt we could really learn from if we did more work, a bit more research on that here. There were a fair few barriers to this area. Some were federal and state policies that are in existence around benefits requirements and employers trying to keep employees under 25 hours to avoid those requirements. Trust issues of having business engaged as a true partner in doing some of this research and applying it. Overgeneralizing the dollars, of course, and then how we could actually identify true translators and champions from the employment sector to really help take the research and help us understand what additional resources needed to move this forward. How am I doing on time?
You have 1 minute left.
Okay. So I'll do education and housing quickly. Education was really looking at the mechanisms that connect health and education. Challenges were really about the entrenchment of how we pay for education and school system equity challenges, tax policy, and we talked a lot about very similar potential audiences here and really focused in on the local school system and calling that out, and as well as the anchor institutions. And then finally, housing. Here we talked a lot about the housing conditions and the impact on health, trying to connect remediation programs with the health outcome, asthma, let's say, and children's hospital healthcare institutions, and the investment that they're making and how they could tap into community benefit to actually improve the housing conditions of the community. We also talked about the role that neighborhood quality plays around economic vibrancy, social connectedness, and civic engagement, and the importance of having affordable housing and the implications when housing is no longer affordable and folks get pushed out of a community, and the challenges and understanding the challenges and the drawbacks from gentrification and the impact on health. And there, a lot of the audience was really developers, zoning boards, community development, financial institutions, bankers, and again, those anchor institutions.
Wonderful, really rich stuff here. Phyllis.
Okay. So I want to preface my comments by saying that I had a very passionate group of people that I worked with, and if I miss anything, feel free to add. Just in terms of the process, we sort of did our own thing. Took some time to reflect on all of the conversations that were going on today, and things that were missing in those conversations that I think adds a little bit more richness to the conversation that we had. And I want to also say we didn't agree on everything. We had some strong assertions and we had some strong pushback. So we were a very diverse group, and we had some explicit commonalities where we shared some of the same views, but then we also had some subtle disconnects in a few areas, but it was all good. So in terms of the area that we had was the root causes, and mixed views. I mean, because I didn't add my opinions to the table, but there was a sense that, we really already understand the root causes. However, the folks who are working in the social and behavioral sciences feel like, we got a lot more work to do in understanding those issues. We talked about some of the issues as root causes and not specifically as research, but we know the impact of poverty, and we cannot discount the impact of capitalism, which came up a lot in our conversation. In terms of who we need to talk to, we've pretty much understood that it wasn't really clear that when we all say root causes, we were saying the same thing. So the medical community or the hospital systems, when they say root cause, or docs when they say root cause, very different than communities when they say root cause. So we have to recognize that interpretations of the language is different, and we have to be mindful of that and mindful of who presents it, depending on who the audiences are. Now, when we got to audiences, one person said everybody should hear this information about root causes, but we started more specifically with the practice community, the people who are out there making the decision. That includes the policymakers, and that this is a conversation that doesn't happen. The audience is not the end game. The audience is engaged through the process. Specifically, when you're talking about community, we say you need to have the right people at the table early, and that's a quote from one of the participants. It should be an engaged partnership to really be able to move on root causes. Something that was missing from the discussion was this notion of social movement, that to really do this work, and the importance of doing this work is sort of what's the end game. And that throughout all of our conversations, even today, it was noted that no one mentioned the social movement. We did kind of clarify, get to a point where we agreed that what we heard, everyone doesn't need to hear it, but it does need to be situational, that we do need to take account what's going on in the context. And then if we had to engage one other important audience, it need to be community leaders in the conversation, and people who can implement the solutions. Okay. In terms of challenges, obviously funding to get grant, the way the funding structures are, and I think others have alluded to this, that sometimes when the funds do come from research, they only will cover a piece of the work, and working on root causes is very complex. And so the research is lacking, even though it may be there, to capture, it lacks in its ability to capture the complexities of the issues and the root causes. And that we probably, this may be one area of research that we still also need to consider, is how do you deal with the fragmentation of the system? That we have systems that are perpetuating many of the problems that we see. And we have not looked really contextually at how these systems are impacting what we do. So challenges, we had a lot of them. And others were the disconnect and sharing information. Folks are doing research in one space, not connecting them to others in other spaces. Different disciplines are doing work, and that work is not coming together. Determining causality is difficult. And if you use a partnership model, we need to consider capacity. So even though we talked about engaging community, we also know that who does this research needs to have the capacity to do the research. And perhaps one of our strategies should be thinking about ways in which we can build that capacity in communities. We raised the question, should we be talking, especially when we talk about communities, should we be talking about causality or should we be talking about association? And when we look at sort of the time deliverance factor of making those changes, what's most important, what takes longer, what can be done quickly. At least one of our members said very few people have a vested interest in changing the structure and these root causes. So even though we may know that we should be talking about this broadly, is there a commitment to changing the structures that we have? So in terms of funding, and I think I'm almost there.
Yep. No, that's right.
Who should conduct the research? One person said the people in the room. And then we kind of departed from that to say not everybody. Depends on the situation, because we have to take into account the vested interests of the people who are doing the research and the bias in the research. It should be situational. So just because we are academics and we know how to do the research, we have the capacity, doesn't mean that we should be the ones that are doing it. So around funding and resources that are needed to move an agenda like root causes research, definitely money. Time. When you look at for academics, the demands of teaching, other scholarly activity, the time to do this kind of research, especially when you're talking about engaging communities, is a huge demand. We need greater capacity, not just in the academic community. And we think others doing this research and moving this research is a resource. And then we need an infrastructure. So we do all of this work. We need an infrastructure to move it, to collect it and move it, and to share it. And that's important. So last few comments, we just let folks kind of wrap and just do a wrap roll around what they thought. Strongly, we already know the root causes of many of the problems we see. We need political will. Sustainability of the partners and the partnerships to move this work is essential. And then we have to move beyond just sitting with the community to what the next step is and getting this work to move. You need clear solutions, you need a clear definition of problems, and then you need the ability to move on those. We need to shift the minds in the field that we do have evidence. We just have to agree that this is important research to do. We lack public accountability, and that if you recognize that 60% of the public funds, at least one person reported that, 60% of the funds that are out there are public funds, but they're not being dedicated towards the things that we think are important. And then someone mentioned the whole issue around root causes, and that we've sort of dismissed the concept of civil rights, and that we just have lost, our way and where that fits with really recognizing, raising this as an issue and moving it as an issue. And then we need to update our methods of research, that perhaps the methods and the strategies we're using right now are not sufficient to not only gather the deep understanding of what's going on, but also to move it. And I think that's where I'll stop.
Wonderful. Very
Okay.
excellent. Great conversation, it sounds like.
So it's great.
That's great. Thank you.
Our group talked about the research needed to understand the impact of policies, practices, interventions that aim to improve population health. It was a very wide-ranging conversation, and I think I'm going to try to distill it into three big ideas that cut across some of the different topics that people address. The first was really we need better ways to measure value when it comes to population health improvement interventions, and to make the business case for why these interventions do they have a return on investment or a social return on investment. And our group also warned against trying to monetize some of these interventions when we talk about their positive effects, and better ways to get to the communication, to communicate the positive effects in a simple, understandable way to people who need to know. The second sort of big area was frustration that our group had about the compilation of even knowing what research has been done that does show the effects. And on the other hand, some of the compilations that are out there, there seems to be a lack of awareness among communities that there are tools for evidence-based policies and practices that they can draw on, and often there's a lot of lack of awareness on that. The third area that people talked about is the difficulty in measuring multi-sector collective impact type initiatives that do have so many interventions, and it's very difficult to evaluate what interventions led to what impact, and just the difficulty of the complexity. So those were our three big areas.
Great, thank you very much. So bringing up the rear, Martha.
So, like everyone else, this was a challenging sort of series of things to accomplish in a short period of time. Our group was made up, I would say, almost probably exclusively of academics, so I think that's sort of an important kind of thing to take note of. And a couple of us worked both in this more full total population health world, and a couple worked more in the bridging of the medical care and the sort of more traditional total population health. So just those kinds of things informed some of the areas. We kept coming to things that were methods and infrastructure, and we decided to put some overarching principles together. So before we come to our three very broad areas, we said for everything that we think that we need to do to study, we need to have equity subgroup analyses in all studies. So that's kind of a given. Another given was wherever cost was relevant and we could capture cost, we need to capture cost. And another point was that we need to build data systems that are connecting EHRs, public health data, social determinants of health. So those things need to sort of come on board so we can really answer some of the really pressing questions. Finally, a principle which sort of I think Mary Lou just talked about is that the challenge of multifactorial interventions and getting people who fund these kinds of studies to understand that there ain't just one thing that is going to happen. Sometimes we have a package of things we need to look at together is sort of an important issue. So going from the sort of absurdly broad to somewhat narrower, these were the three areas that we came up with after we did a couple of round robins of areas that came to people's minds. In general, we thought we needed to get into interventions that were crossing sectors, and we did not specify what those interventions would be. We said, not surprisingly, that the way you would do this would be have investigators who were in transdisciplinary teams, and depending on who was most passionate about it, you would be looking for probably foundation support. Might be simply health foundation kinds of support, but you might be looking also broader at foundations that looked at quality of life, that looked at sort of social circumstances of people. But, you know, again, if you were going broad, you would want to think that there would be benefits for all of the sectors in this, and you would get them to sort of pile on. You know, this would be done with an audience in mind of decision makers in government and in funders and in legislators. Second one we talked about was, you know, what do you do about prioritizing resources where dollars are scarce? How do you sort of think about where you get your most bang for your buck? We thought about this in two different ways. One was in thinking about if you were to take all of governmental monies and think about a global budget for them across sectors, you know, how would you allocate? And obviously this is a complicated modeling sort of situation to get into. The other suggestion was that we think about a global budget that talks about health and health care together, both in the public and private sectors. And what would you do in terms of thinking about where to invest in that sort of slightly narrower notion of what creates health, sort of chopping off the other sectors, staying more with traditional public health. The audience for this would be obviously policymakers at the local, state, and federal levels. OMB could be certainly interested in these kinds of things. Again, conductors would be modelers, economists, but you would need to have people who were from the, you know, the decision-making sector sort of advise people about the kinds of challenges and decisions that they face in order to sort of inform how you would develop the questions you would ask. Who would pay? If a health alone, it would be foundations focusing on health. If cross-sector, you would be, you know, going broader to whatever government slush funds exist that cross sectors. I'm not aware of what those are. By the way, we never talked about challenges because we just assumed that challenges were like huge. so we didn't fill in that blank. We ran out of time. The third one was actually much narrower, and it was to evaluate the effectiveness of using the term health as a motivator for action in other sectors. Not only with other sectors that have nothing to do with health or healthcare, but also with our healthcare partners. The audience for this one would really be population health researchers and advocates. Are we doing ourselves any favors by framing things in terms of health in all policies, or calling this the roundtable on population health? Or should we be using different kinds of language in order to affect what we actually want to affect? Who conducts this? This would be, you know, our communication scientists, our public policy analysts, and we would think that the funders of this would be the foundations who have been so pivotal in thinking about broadening the notion of health and social determinants of health. And I think that's it.
Great, wonderful. So at this point, I'd like to invite the participants in the groups to just add or embellish on any points that your fantastic moderators have made or maybe weren't able to frame in quite the way you wanted to frame it, because we all take in the information through our own personal filters. And then, so sort of plenary conversation, and then I want to have us think about what wasn't talked about, given the pre-meeting survey and some of the presentations this morning. But, so first, any just additions or embellishments on the reports from our moderators? Pardon? Subtractions, yes. Additions, deletions, subtractions, modifications. I know, it's late in the day and we've been here all day, but come on. Got to get those synapses working.
So I know I'm not supposed to say anything, but I will add one that Chris raised, since I have the notes, she might not recall, that one of them was around generating standards of evidence for population health, and really thinking about that transdisciplinary
Right.
framework and what those standards would look like, because every discipline loves their standards best.
Yes, that's a great point, sort of a necessary but definitely not sufficient. Phyllis,
I'm going to violate it too. because,
please, violate away.
Just wanted to add, and I thought David might say something, but as a resource, the technology, the information is grand. world of data that we're collecting is a resource. And, he said something that was just really goes really to the heart of what we've been talking about, and that is being truly interdisciplinary, not just, symbolically, but really being that in an environment of respect, that will enhance the quality of the resource, and right now it's a challenge.
Great, excellent point. George?
Yeah, I'm thinking about the course of the day and the root causes challenge that our table had. And one of the presentations yesterday from Ana Ruiz, and I forget her last name.
Diaz-Ruiz.
Yeah, that's right. Thank you very much. But I thought her presentation was particularly insightful in a number of ways. One of the things she said was was thinking about the complexity of population health and the research challenge as looking at the complex adaptive system, and that in those systems you really needed to look at rules and the way things sort of work within that system. And you need to change your thinking about that. And if that sort of, and we heard a little bit of that this morning, I think, although it wasn't labeled that way in terms of the conversation about the percentages adding to more than 100%, which really really has us thinking about the fact that this really is not only complex, but it's situationally dependent in terms of where people live and so forth. So does that change our thinking about root causes and the kinds of things we ought to be thinking about in terms of identifying factors that would be useful and identifying policy and other approaches to actually improve health across the country? And so it's more of a question than a suggestion or an addition or a subtraction. I just wonder if we're thinking about root causes in all the ways we should be thinking about it.
Great question. Anybody from the moderator or the group at large, please want to take up George's challenge to us or thinking. I think Chris is going to get up, but I think it does. I think one of the conversations today and yesterday, and really I think more broadly anytime these issues come up, is about the need to adapt different disciplines, the transdisciplinary, and bring, whether it's system science thinking or even quality improvement, statistical process control methods into thinking about these things, because it's so complex and multifactorial. A much more illuminating answer from Chris is forthcoming.
No, I don't think so. But I just wanted to say I don't think it necessarily changes our questions about root causes, except insofar as we have to pay much more attention to the interactions among root causes. And I think that came up a lot from our group. And more importantly, it has to really revolutionize the methods that we're using and the kinds of evidence that we put together to provide answers for population health. At this point, I think the vast majority of people doing research are still doing regression analysis. And we have to move beyond that. It's an important element, but we have to push our methods forward.
No, I underscore that many times. And with the explosion of the data and technology that we've all talked about, there's a tremendous opportunity there, but there's also the cautionary note of, finding, associations and other things that really don't exist or lead you down a rabbit hole. So other comments on the presentation so far, and your discussions at the roundtable, reflections on these priorities. Again, the product, I'm going to turn to Paula to help us understand what Paula and the roundtable are going to be doing with these summaries, so that we kind of understand what our comments are helping to shape. Paula, you want to summarize that or remind us what our challenge today was and how it's going to be used and inform the broader movement towards population health research?
So the broad goal was to have the conversations today, and then the survey
inform future discussions about a research agenda. I think some people thought we were going to come out of this meeting and have a research agenda for population health, and honestly, I never thought that was going to happen, but that's too big, and people come at this from too many points of view. So to be really honest, I don't know exactly what is going to happen from here, other than the richness of the information we've gotten through the day, and again in the survey, and then these breakouts are just fascinating amount of information to me. We do hope to use that on the roundtable to think about other things we might do in the future, how we're going to collaborate more with this new population health science organization, and then really we should get our conversations and the discourse we've had today out into the public domain in multiple formats. And I don't know if Alina has ideas about next steps in that regard.
Great, Alina.
Thank you. Just a quick caveat and then a few add-ons to Paula's comments. This is an IOM roundtable. It's not a consensus study process, and so there won't be recommendations that come out of this, as I think George mentioned early on. But there are a number of things that the roundtable can help spur and get organized as a result of this. Some of you who've been following us for a while know that we're in the process of organizing 3 action collaboratives that are going to be doing sort of sidebar activities related to the roundtable, but that allow us to engage a broader circle of partners. One of those is going to be focused on population health science, but we really wanted to wait until yesterday's event took place to see where that takes us. And so be sure that if you're interested in how that will shape up, we have your email address, and if you've registered for the meeting, we do. The other thing is, if any of the groups today were really engaged and you really wished you could continue the conversation, there's a way to do that. So roundtables and forums at the IOM are able to put out individually authored opinion pieces. They could be article length, or they could be like an op-ed, but they're a way to get information out in fairly quick order to the field to help shape the dialogue. And so if you're interested in doing something like that, let us know, and we'd be happy to support that, help you organize a conference call and host it, et cetera. Thank you.
Wonderful action steps. And I would just say, now that we have this new association, Chris, and there's another step that I would encourage, that where you can go further than where the roundtable can go, in that one of the role of associations is to advocate to funders, and we've talked a lot about it in terms of each of you reporting back on what are the resources. Well, one of them is money, obviously, that you need to do this agenda, and taking whatever comes out of this forward directly to research funders in both the public and private sector, I think is a potential action step that, again, the IOM can't do, the roundtable can't do, but you can take what you can, and the individuals can also do that, because I think it came up in every one of your presentations as you think of the challenges and what is needed to conduct the research, like you said, a focus on equity in every question, or new methods, or a focus on costs. Those things will not happen unless the people paying for research start asking for them. And so I would just really encourage the community broadly to take these messages out further than just the sort of public conversation that also needs to happen. So with that, I want to encourage, we have still more time, but given what Paula and Alina have described, and given what we've heard and you've discussed, what didn't get discussed today? What are you concerned about seeing happen or not happen that needs to be put on the table as we think about the research priorities for population health? Is there anything, do you have a burning issue or a concern that today's conversations have raised? And have the energy to get to the mic and tell us. Chris.
So I'm close to the mic, and so it doesn't take much energy to get here. One of the things I'd really like to see research designs develop for is to look at the approaches that are actually being taken by accountable care organizations to improve population health, and look at the extent to which they're really bringing in upstream determinants, and try to get a sense of the relative outcomes of the organizations that are really still focusing in the individual level and those that are bringing in the upstream determinants. I think that that's critically important for the concept of population health. And if we don't address it, I think we're going to lose a battle.
Yeah, no, I think that's a great point. And I would just add to that throughout the conversations as well, a lot of what I heard people saying is we need to understand what's happening right now in different sectors and what's working out of those initiatives, because this is a very big country and we love to reinvent the wheel. I mean, we do. And there's just too much information. And so the example you gave is a perfect one where other health systems and other ACOs are going to start doing what partners tried 10 years ago and it didn't work, and now they've gone on to a better approach. And so this opportunity to not waste time and opportunity and resources on strategies that don't work or don't pass the sort of smell test of, the emperor has no clothes. This isn't population health. So.
Just one other additional comment. We've spent most of our day talking about the social determinants of health and also about health care and really how those things interact to produce health or lack of health. I think we shouldn't forget, and I think many of us in the public health realm do forget, about behaviors. It's really important to remember that tobacco, physical activity, nutrition are the top killers in the US. And I think sometimes when we get to the sort of macro level, we forget that there are also health behaviors, and those health behaviors are impacted by the social determinants. They're really determined by the social determinants. But we need to look at those interactions and not leave them out of the equation.
Now, a few of you brought up the issue of the complexity of our world and the complexity of interventions and evaluating and doing research on these multifactorial interventions. Where are some, examples of where you see that happening well? Where can this field turn? And what are some lessons learned and strategies that we can, are we already using, or can we adapt to do that better? Because this is an issue across, healthcare, health, and all the sectors, housing, employment, et cetera. Any thoughts on that? Because we're good at saying what's hard to do. I'd like to know who's making progress in addressing the challenge.
Did Jeff leave?
Jeff Levy?
Yes. Okay, so I'm going to just channel Jeff because okay. I wouldn't have known this of my own accord. But he talked about the notion of the sort of successes in tobacco control and how he would, presentations would be, well, what would be the one thing that had an impact on the lessening of use of tobacco? And, is it taxes? Is it physician counseling? Is it public campaigns? The answer is, you need to get a critical threshold of many different things happening at the same time. And so if somebody who is interested in funding research says to you, well, just show me the one thing you're going to test, when you're working in this realm, you have to be able to say it doesn't work that way.
And are funding agencies receptive to that, is your sense? Are we seeing more receptivity?
You've gone beyond my knowledge base.
Well, I think I would just say from our work on dissemination implementation science in partnership with the National Institutes of Health and many of the institutes and centers, and there's an annual conference in December on D&I science, this focus on complexity is certainly, and context specific, and the importance of context, because people tend to say content is king, you got to have the right content to disseminate, but context is maybe the queen, or you could pick your gender. They're just as important.
Yeah, I just wanted to add to this comment because I was sitting here thinking about a friend of mine who is taking a 6-month sabbatical just to sit and study and learn about complexity science as a different way to frame how you conduct science. And I think, we're in the midst of a situation where that is absolutely going to be required. So I don't have that expertise. That would be an area of expertise to bring in, I would think, to the roundtable and to how we even think about going forward. Because the traditional methods, as was just noted, the regression analysis approach, obviously, isn't going to take us where we need to go.
Bob.
Bob Griss with the Institute of Social Medicine and Community Health. I'd like to say that complexity issues are exaggerated. And what's missing from the discussion today is a focus on the politics of the social determinants of health. When vested interests are trying to stave off public policy and regulations, they talk about the complexity and how we really don't really know what's going on. So even in this tobacco control issue, which I guess is one of our best examples in public health, the fact that FDA has been unwilling to address the menthol issue or the e-smoking, e-cigarettes issue, the public needs to understand the way the tobacco industry is influencing that process. And the fact that it doesn't come up at a conference like this needs to be understood. Lisa, you used one of the quotes that about every system is ideally designed to achieve the results that it gets. So much of the work that we do is focused on tinkering with the system so that we don't have to address the root causes. The root causes really are the lack of commitment to the principles of public health, the principles of equality, the ones that are embedded in the civil rights movement, which had vitality when there was a social movement behind it, but is lacking now. Mm-hmm. I'm not hearing that kind of focus in our work. So I'm feeling that we are fooling ourselves by saying we have a crucial role to play, of course, with the community engagement, but community engagement needs to be driving the process around what's sick in our healthcare system. It isn't visible when you just focus on individual health status, even though that's a terrific measure of inequality. It comes out when you start doing comparative research within systems and between systems. So international comparisons are highly relevant in the way they integrate medical care and public health and make that a seamless financial system. I'm not hearing recommendations about doing that. Sure, the NACO representative talked about the erosion of funding for public health, and I'm sure he feels it intensely. But the political movement to challenge that was not identified in this conference, and that's, to me, where the solutions really lie.
Well, thank you, Bob. And in fact, I think it was Phyllis who talked about the social movement issue and really the political will to act on some of the science that we have. I would say, just as an aside, because those were very powerful comments, Bob, that one example of where international comparisons in an IOM report, the Shorter Lives, Poorer Health report, and there's a particular graph on one of the pages about the life expectancy for women and how over the last 30 years, women in this country they were already at the bottom compared to OECD countries. Now we're not even on the graph. We're so far below. And in a time of Lean In and Anne-Marie Slaughter and all the other commentaries about the role of women in today's society in America, nobody's picked up that it's killing us compared to women in other countries. So again, great science, but it's that report. I was in this very room when the Rose and others organized the sort of launch of that report, and I was very disappointed to see how little uptake reframing the conversation in this country that report had, compared to, say, to air is human or unequal treatment, where it really did help change the conversation.
Good point.
Yes.
Jean McGuire from Northeastern. I wanted to link two comments earlier from Ron Pollock and Janelle as maybe speaking to another research agenda here. And that's relative to the extent that we believe that some of the resources and obligations for achieving population health are within the healthcare industry, and we watch the change that's going on right now. Ron both spoke to what's happening in terms of increasing coinsurance and other consumer level costs that could, totally sabotage the effect of people having access and using their care more appropriately. And Janelle raised the question, well, if we were successful in population health, remember all those revenues and all with the entitlement program stay the same way. But in fact, the whole system, if we're successful, should change. And the whole system under the ACA should change. And so some hospital beds should close, and some costs should go down, and some resources should go to other sectors, not the healthcare industry. And so some piece of research, I think, since we both want and need, and the healthcare industry needs to be able to drive and invest in population health, but faces a mixed incentive, disincentive to do so in terms of what do the horizons look like and what's their role. But the role can't just be keep making the system whole. Or I don't think that can, maybe that's the research question. So I guess I would add that to the panel of questions. Thank you.
Great question. And the issue of sort of the ROI, we've mentioned, I think the cost dimensions need to be embedded in all studies. Martha mentioned that as a principle, and cost and ROI and sort of getting the business community engaged has certainly come up. But a big challenge is when the ROI, the cost is in one sector and the R is in another sector. And certainly in child health, that's always the case because of the time horizons, but also the benefits of better asthma care are felt in the schools with presenteeism, not in the healthcare system. So very challenging. Yes.
Hi, Cray Milford. I'm a tinkerer, I suppose, but I'm also an incrementalist. And the interesting thing that I've found as I listened through this is that I sit on the delivery system side as a clinician and as a medical director on that side. And I think there is actually, to steal the IOM's phrase, there's a chasm between population health and management. And I would love to see part of the research agenda pull those two worlds together, because there's a ton going on in the ACA space and ACO space. I think provider systems are dying to know what the real impact of their work will be. They're being pressed to do so, and they're investing a lot of money to do so. And they could use a lending hand from the research community. I hope that we create a strategic research agenda to get there so that there's a lot of fat in the system that we can address collectively before we get to some of the really tough questions that have been posed today. But there's a lot of low-hanging fruit.
Thank you. And to that point about the research agenda, again, knowing the roundtable cannot do this, just caveat, and Paula's disclaimer about, this was a survey of a convenient sample, and this is, who was in the room. The reality is that writing it up in a journal can make a huge impact, even just Paula Lance, Umish, because it moves the conversation forward. And so I think it is really important to get that codified and out. Yes, Martha.
I just want to follow up on Bob's remarks a little bit, because it occurred to me as we sort of sat around thinking about root causes as an area to investigate. I've always wondered, if we don't have the political will in this country to change root causes, why is the research community, sort of hacking away at that? Do we think that if we provide one more study that suggests the root cause of poor health is poor living circumstances, that people are going to change their mind? It continues to be a question for me as to where we put our energies and our will. And some of this is about, what's the research space and what's the advocacy space.
Phyllis, do you want to Yeah. Okay. Well, Martha, I think you raised a really a good cautionary note of it's not that we need more research that poverty is bad for your health. I mean, we sort of know that. But at least at one level, because of course I run an association of trying to get more research out there, I've found in my conversations with policymakers is that having, first of all, a body of evidence ready, the old, garbage can theory of policy translation. When the window of opportunity opens, you go into that garbage can, pull out the evidence that's been there, and use it because you can actually make a difference. But also, that evidence has to be recent. Because policymakers, on the question about insurance and the impact of uninsurance, I mean, how many reports has the IOM had to produce on why insurance matters, and we keep having to re-examine it? Because the question from a policymaker will go, that finding is 5 years old, that finding is 10 years old, I need more recent data, the world has changed. And so I think there's also an argument to be made for continuing to produce evidence that is current in its context and shape, because that's what folks are going to ask about if they have any interest in using it. But many will not even ask that question. So, Phyllis?
Oh, yeah, but I would argue that because I too, I'm old enough to have seen a lot of this research over and over again, and while I value it and believe that it has value, where I think we fail is in being strategic and seizing opportunities when they arise to begin to use that research in a way that can move the needle. Because what I've also seen is that these root causes have become very entrenched, and we don't make any real gains on them. So, I think in addition to new methods of how to study, we need new methods and approaches to how to influence change on some of these measures. And I think one step towards that is really being strategic. I was kind of tickled in my group when I asked, if you did root cause research, who you talk to? And they said everybody. And if you're talking to everybody, like the question says, are we being strategic? And so I'm not ready to drop it yet if there's a need for current. But I'm certainly tired of not
using what we have
in a strategic way.
Yeah, no, excellent point, Phyllis. George?
So, this conversation very, very, very poignant to the point. The thing that I think that the Robert Wood Johnson framework contributes is that notion of make health a shared value. So I think the research agenda related to that has to do with implementation research in terms of how you appeal to people so that you get a shared value. I think there's a research agenda around how you do that effectively in terms of communication and so forth, although I'm no expert in that area, and somebody else could tell me that's the wrong way to think about it, and I'd have to respond to that. But it seems to me if we only focus on root causes in the sense of poverty and so forth, which are really critically important, we're missing the opportunity to really think about how we change minds and so forth. I reflect back to the roundtable we had on movements, which is archived, and I'd recommend it to all of you. It proposed a lot of provocative questions about how you create activity that basically recruits people who are different from you to an idea or a movement, a social change. And I think we need to get a lot smarter about that. So if there's I don't know if this defines a research agenda, but to my mind, being not a researcher, it's a line of inquiry and a line of learning that we need to collectively sort of participate in and benefit from.
George. So it is 4:45, and folks have been very diligent. So I think David is ready to give us our marching orders and to thank us all. But with that, thank you to the moderators of each of the sessions.